Welcome back to the deep dive. This is where we stop just, skimming the headlines and really start to master the material.
Exactly.
And today we have a topic that's, well, it's mission critical for any aspiring MD anesthesiologist.
Absolutely.
We're moving past just giving the drugs and into mastering the most critical moment of any case, the end.
You wake up.
Precisely. We're doing a comprehensive, high-stakes deep dive
Yeah.
into neuromuscular block reversal, focusing specifically on that classic comparison, Neostigmine versus Sugammadex.
And our goal here isn't just about clinical practice, right? It's about structuring this knowledge to absolutely nail your theory papers and, of course, the Viva.
That's the plan.
Good. Because for the MD anesthesiology exams, especially for universities with, let's say, a very high standard, this isn't just another topic.
No.
It's the point where pharmacology, physiology, and patient safety all crash together. I mean, if you think about modern anesthesia as a journey towards, let's call it progressive precision in patient safety.
I like that.
Then reversal is the final, absolutely crucial step. So this deep dive is designed to take you way beyond the textbook, into the details that examiners are really looking for, the doses, the limitations, the clinical thinking behind the choice.
Okay, let's start by framing it then. Let's define the stakes. Why do we even reverse neuromuscular block? It seems obvious, but what's the evidence telling us about what happens when we fail?
That's the perfect starting point, because we used to be a bit more relaxed about some residual weakness.
Right, a little bit was considered okay.
But the modern literature is fiercely, fiercely unforgiving of inadequate reversal.
So what's the goal?
The primary objective, and you have to state this clearly, is the complete elimination of residual neuromuscular block, or RNMB.
And that has a number, right? A definite.
It does. It's objectively defined as a train of 4 ratio, a TOFR, of less than 0.90. That number, the 0.9, is non-negotiable. It's the current standard of care.
And the data backs this up.
Overwhelmingly. I mean, large-scale outcome data shows that simply using reversal agents is associated with a dramatic reduction in severe postoperative complications.
Like what?
Specifically, the risk of coma or death within 24 hours of surgery. The protective effect is just staggering. It's quantified by an odds ratio of just 0.10 when you use a reversal agent.
An odds ratio of 0.10.
That statistic needs to be front and center in any answer you write on this topic. It's that important.
Okay, that is profound. It elevates this from just a good idea to a clinical mandate.
It does.
But what about when we don't meet that standard? I mean, how common is RNMB in the real world, especially if we're not using monitors?
The incidence is, frankly, alarmingly high. Without quantitative monitoring in the PCU, we see RNMB, that TOFR, less than 0.9 in about 30 to 50% of patients.
30 to 50?
Yes. Think about that. 1 in 3, maybe even 1 in 2 patients could be leaving the OR with inadequate respiratory protection. That's a huge systems failure.
And it leads to specific risks, I imagine.
Directly, yes.
So let's talk about those risks. I think we all focus on the diaphragm, but it goes deeper, doesn't it?
It absolutely does. The consequences are far-reaching. First, you have the obvious ones. Critical respiratory events, hypoxemic episodes, just impaired control of breathing.
But it's not uniform weakness, is it?
That's a key insight. The smaller, faster twitching muscles of the upper airway are disproportionately affected. This means you get impaired pharyngeal and laryngeal muscle function,
Which leads to
airway obstruction. And critically, it impairs swallowing. You get decreased upper esophageal tone and discoordination of the swallowing muscles. And that failure of protective reflexes is what drives the risk of aspiration.
And is there a direct link from that to, say, long-term morbidity?
The link is inescapable. Retrospective data, very clear on this, shows patients who did not receive reversal agents had a 2.26 times higher risk of developing postoperative pneumonia.
2.26. That's a hard number to ignore.
You can't. And it also increases PCU stay, hospital stay, and costs. So when you put it all together, the OR of 0.90, the 30 to 50% incidence, the 2.26 times pneumonia risk, you have the complete argument for why we must reverse and reverse properly.
That's the foundation. Okay, let's pivot to the exam itself. Examiners love to set traps around this, especially with monitoring.
They do. The most common trap is asking you to rely on old clinical signs.
Like the head lift.
Exactly. You must acknowledge the history, the 5-second sustained head lift, but then you have to state unequivocally that it's an unreliable standard. Objective quantitative measurement is the only safe way.
And what's the evidence that kills the head lift as a gold standard?
The evidence is definitive. A patient can do a sustained head lift for 5 seconds with up to 33% of their receptors still blocked.
A third of them.
A third. And other signs like tidal volume or a strong hand grip, they're even worse. They can look totally normal with a massive 70 to 80% of receptors still blocked.
So if you rely on those signs, you are routinely sending patients to recovery with dangerous levels of paralysis.
That's the bottom line.
Okay, so if the head lift is out, what's the quantitative standard we need to quote? And is there any clinical sign that's even a little bit better?
The objective standard for safe extubation is a KO-F ratio greater than or equal to 0.90. That's the number.
And you mentioned acellular myography, AMG.
Yes, that's a key Viva point. If you're using AMG, the threshold is higher. It's 1 point over. That's because AMG is known to overestimate recovery compared to the true gold standard, mechanomyography.
That's a great detail.
It shows you know the nuances. And as for a better clinical sign, if an examiner pushes you, the one to cite is the ability to strongly oppose the incisor teeth against a tongue depressor.
Why that one?
It better recruits those crucial pharyngeal muscles. It correlates with a TOF ratio of about 0.85 on average. Much better than the head lift, but still not a substitute for a monitor.
Understood. Okay, to really get the difference between Neostigmine and Sugammadex, we have to agree on the battlefield, the neuromuscular junction.
Let's do a quick review. Let's zoom right into that postsynaptic membrane. The adult nicotinic acetylcholine receptor, the NOE-CHR, is a protein complex, a pentamer.
5 subunits.
Right. And for us, the key is it has 2 alpha subunits. Acetylcholine, or eighth claw, has to bind to both of those alpha subunits to open the channel.
And that's what triggers the action potential.
Yes, it opens for just a millisecond or two, sodium floods in, and you get muscle contraction. Then, almost instantly, it's broken down by acetylcholinesterase, or ACO.
So our non-depolarizing muscle relaxants, the NDMRs, are basically molecular decoys then.
Perfectly put. They are competitive antagonists. They look just enough like AC to sit on one or both of those alpha subunits.
So they block the real AC from binding.
And that prevents the channel from opening. Blockade.
This setup is perfect for explaining the 2 reversal agents because they approach this problem from completely different angles.
This is the single most important concept for the exam. The goal is to beat that competitive block. Neostigmine takes the indirect route.
Indirect how?
It doesn't touch the relaxant. Instead, it attacks the enzyme, ACE. It inhibits the enzyme from breaking down acetylcholine.
So the body's own AT builds up.
Massively.
Yeah.
You increase the local concentration of aceti in the synapse, and you rely on brute force, on sheer numbers, to outcompete the relaxant and kick it off the receptor.
Okay, that's the indirect approach. What about Sugammadex?
Sugammadex is the direct route. It completely bypasses the whole cholinergic system. It's a chemical that physically binds to the NDMR molecule itself in the plasma.
It just grabs it.
Forms an inactive complex. This physical removal of the relaxant creates a massive concentration gradient. It literally sucks the remaining NDMR molecules off the receptor and into the plasma to be captured.
It's a scavenger.
A molecular scavenger. It's a fundamentally different process.
That split indirect competition versus direct removal is absolutely key.
It is.
Before we jump into the drugs themselves, just a quick word on monitoring. Specifically, the phenomenon of fade. Why do NDMRs cause it?
Fade is the hallmark of a non-depolarizing block. It's that diminishing response you see with repetitive stimulation, like in a train of 4.
And that's not just from blocking the main postsynaptic receptors.
That's a common misconception. The overall weakness comes from the postsynaptic block, but the fade itself is mainly from the block of projunctional nicotinic receptors.
The ones on the nerve terminal itself.
Exactly. Those projunctional receptors control the mobilization and release of acetylcholine. When they're blocked, the nerve can't keep up with high-frequency demand. That drop in output is what we see as fade.
Which again just hammers home why we need to monitor.
You have to. You titrate your block intraoperatively, maybe a PTC of 1 to 5 for a deep block or 1 to 2 twitches for maintenance. But at the end, you need that quantitative monitor to confirm you've hit that TOFR of 0.9 or higher before you pull the tube.
Okay, let's dive into Neostigmine, the workhorse, the traditional agent. It's still critical, especially because it's our only option for some relaxants.
And its mechanism forces you to understand some really important complexities.
Let's start with classification. For the exam, we need to be precise.
Neostigmine is a reversible anticholinesterase inhibitor. That's the class. Chemically, it's a synthetic compound with a carbamate group, and, this is crucial, a quaternary anamine structure.
So walk us through how it inhibits the enzyme. Where does it bind?
The ACE enzyme has 2 key sites, an anionic site and an esteratic site. Neostigmine looks a bit like AC, so the enzyme recognizes it.
Good.
The quaternary positively charged part of neostigmine binds to the negative anionic site, and the carbamate part of the molecule binds to the esteratic site. This forms a stable but reversible complex.
And that just gums up the works?
It gums up the works. It inhibits the enzyme so it can't break down the naturally released acetylcholine.
Which leads to that massive increase in AC at the NMJ.
Correct. The HE concentration just builds and builds, and that's what allows it to outcompete and displace the relaxant from the receptor. You're winning by flooding the zone.
You mentioned a subtlety before, that neostigmine has its own direct actions. Why is that important to know?
It's important because it helps explain one of its biggest limitations. Neostigmine isn't just a passive inhibitor. It actually has some minor direct agonist effects on the receptor itself.
So it can stimulate the receptor?
A little bit. And at very high concentrations, it can even cause a channel block. This contributes to that paradoxical weakness you see if you give too much to a patient who's already recovered.
Got it. Okay. Pharmacokinetics. You said the quaternary structure was key.
Yes. The quaternary ammonium group makes it highly ionized. That means it's not lipid-soluble.
And the clinical ramification of that is?
It does not effectively cross the blood-brain barrier. This is vital. It limits central nervous system side effects, which is a big contrast to older tertiary anticholinesterases like physostigmine.
And the time course. How quickly does it work?
Onset is about 5 minutes. You'll see the peak effect around 10 minutes. And the duration is pretty long, usually over an hour.
Which can be a double-edged sword.
It is. If you get side effects, they're going to stick around for a while.
And how does the body get rid of it?
It's partially metabolized by the liver and plasma esterases, but a big chunk, 50 to 60%, is cleared unchanged by the kidneys. So clearance is definitely reduced in patients with renal failure.
Okay, dosing. This is where examiners test precision. What's the range and what's the absolute rule about timing?
The standard dose range is 15 to 50 micrograms per kilogram. That's 0.015 to 0.05 milligrams per kilogram.
And the maximum?
You must know the maximum recommended dose, 0.08 milligrams per kilogram, up to a total dose of 5 milligrams in an adult. Going over 5 milligrams gives you no more benefit and a lot more risk.
Now, the critical point on timing. When do we give it?
You never, ever initiate antagonism until you see spontaneous recovery has started.
And what does that mean in practical terms?
It means you must have at least 4 responses to train of 4 stimulation, TOFC of 4 or more. If the block is deeper than that, neostigmine will fail. It just can't generate enough AC to overcome a deep block. That's the ceiling effect.
Okay, that rule is foundational. What if you're stuck without a quantitative monitor and you just have to go by feel?
If you can feel 4 twitches, but you can't really detect any fade by hand, you have to be conservative. Limit the dose to the low end, 15 to 30 milligrams per kilogram. The key message is never overdose, and never try to reverse a deep block.
Since neostigmine floods the whole cholinergic system, you have to give an antimuscarinic with it. Why is glycopyrrolate the preferred partner these days?
Right, because the AC stimulates muscarinic receptors everywhere, causing all those nasty side effects. You need the antimuscarinic to block them, to prevent severe bradycardia, secretions, all of that.
So, glycopyrrolate first.
Glycopyrrolate is the modern standard. The ratio is 0.2 milligrams of glyco for every 1 milligram of neostigmine, or about 10 micrograms per kilogram.
And the big advantage is the timing.
The timing. Its onset profile matches neostigmine's much better. It's a bit slower to kick in, which means you get much less heart rate instability. You avoid that big spike of tachycardia you see with atropine.
And it also doesn't cross the blood-brain barrier.
Correct. It's also a quaternary compound, so you avoid central anticholinergic syndrome.
And atropine.
Atropine is dosed higher, 0.4 milligram per 1 milligram of neostigmine, but its onset is much, much faster. So you get this initial tachycardia, then as the neostigmine kicks in, you can get a dangerous rebound bradycardia. Atropine is really only well-matched for the older, faster agent edrifonium.
Okay, an examiner will want a list of the main adverse effects.
You group them by system. Cardiac is number 1. Profound bradycardia from M2 receptor stimulation if you don't give enough glyco.
Respiratory.
Respiratory is critical. Increased bronchial secretions and bronchospasm from M3 receptor stimulation. This makes it really tricky in patients with asthma or COPD.
Is there a way to mitigate that?
You can premedicate with atropine or glycopyrrolate before giving the neostigmine to try and counteract it.
And gastrointestinal.
Increased gut motility, cramps, and sometimes nausea and vomiting.
Let's spend a moment on that classic Viva question. Neostigmine-associated weakness. The paradoxical block.
This is a critical concept. If you give a big dose of Neostigmine, say 40 millicentigrams per kilogram, to a patient who has already fully recovered, whose TOF ratio is already 0.9 or higher, you can actually make them weak again.
How does that happen? A reversal of the reversal.
It's that massive overabundance of acetylcholine. It just floods the junction and causes persistent depolarization of the postsynaptic membrane.
So it's like giving a small dose of cyclodextrin.
Exactly. You're inducing a depolarizing block. When the non-depolarizing relaxant was still partially there, it acted as a buffer. Once that buffer's gone, the patient is vulnerable to this neostigmine-induced weakness.
Okay, so that brings us to the limitations of neostigmine, which really sets the stage for Sugammadex.
The primary limitation is the ceiling effect. Because it works by inhibiting an enzyme, there's a maximum level you can raise the AC to. Once that enzyme is fully inhibited, giving more drug does nothing. It's futile.
And that ceiling effect is why it's ineffective in a deep block.
Absolutely. If the patient has a PTC of 0 or only 1 or 2 twitches, there are just too many relaxant molecules on the receptors. The maximum amount of SCA you can generate isn't enough to displace them.
And even when you use it correctly, the recovery is slow and unpredictable.
Yes, even with a good dose for a shallow block, you're looking at a median time of 15 to 20 minutes to get to that safe TOFR of 0.9, and it's variable. That's why it's so strongly associated with RNMB when you don't monitor objectively.
Last point here, acid-base status. This is a great conceptual point.
It's a high-yield one. Neuromuscular recovery is significantly impaired by respiratory acidosis.
So if a patient is hypoventilating post-op,
and their CO2 is rising, the dose of neostigmine you need can almost double. This can create a deadly feedback loop. The patient is weak, so they hypoventilate, which causes acidosis, which makes the neostigmine work less effectively, which makes them weaker.
So the clinical lesson is?
You have to fix the ventilation. Aggressively correct the respiratory acidosis before or at the same time as you're trying to reverse.
Okay, let's move to Sugammadex. If neostigmine is about biology, Sugammadex is pure chemistry. It really revolutionized reversal.
It's a true game changer.
So what's the mandatory classification we need for the exam?
Sugammadex is a modified gamma-cyclodextrin. It's the first in a class of drugs called selective relaxant binding agents, or SRBAs.
And that structure, the hollow cone, how does it work? How does it encapsulate the drug?
The cyclodextrin molecule is shaped like a donut or a cone. It has a very lipophilic or hydrophobic core and a very water-soluble hydrophilic exterior.
So it's designed to trap fatty molecules in water.
Precisely. And the steroidal relaxant, like Rocuronium, is the lipophilic guest molecule. Sugammadex forms an incredibly tight, water-soluble, one-to-one inclusion complex by trapping the Rocuronium inside its core.
And that bond is strong.
Unbelievably strong. It's like a molecular cage snapping shut instantly and not letting go.
So it grabs the drug in the plasma. How does that reverse the block at the actual muscle?
This is the elegant part. By rapidly binding and removing the free drug from the plasma, you instantly crash the plasma concentration. This creates a massive concentration gradient between the synapse and the plasma.
And diffusion takes over.
Exactly. The laws of diffusion pull the Rocuronium molecules right off the receptors back into the plasma where they get snatched up by more Sugammadex. You're physically removing the drug from its site of action.
Unlike neostigmine, which is broad spectrum, Sugammadex is very specific.
Very. Its primary target, its highest affinity, is for Rocuronium. It also works very well for Vecuronium.
You said the affinity for Vecuronium is a bit lower. Why is it still so effective?
That's a great question. Vecuronium is much more potent than Rocuronium. So to get the same level of block, you need fewer molecules of Vecuronium at the junction to begin with.
Ah, so because it's a 1-to-1 binding ratio, you just need less Sugammadex to clear them all out.
That's it, exactly. The lower number of molecules compensates for the slightly lower affinity.
And what must we absolutely state that it does not work on?
It has basically 0 affinity for the benzylisoquinolinium relaxants, so atracurium, cisatracurium. If you use those, neostigmine is your only option.
Its speed is its trademark.
Oh.
How fast are we talking?
It's stunningly rapid, usually 2 to 3 minutes from a deep or moderate block.
So faster than neostigmine's 20 minutes.
It's not even in the same league. In some cases, reversing a high dose of Rocuronium with Sugammadex is faster than the spontaneous recovery from acetylcholine.
Wow. And metabolism and elimination.
This is another unique feature. It is not metabolized at all. The Sugammadex Rocuronium complex is stable, inactive, and the whole thing is excreted unchanged by the kidneys.
So it actually changes how Rocuronium is eliminated.
Fundamentally, it shifts Rocuronium's main elimination pathway from the bile to the kidneys. The half-life of the complex is about 2 hours.
Dosing. This is the exam critical part. There are 3 key doses.
You have to have these 3 tiers memorized. First, immediate reversal. Think RSI, can't intubate, can't ventilate. You've given 1.2 milligrams per kilogram of Rocuronium 3 minutes ago. The dose is 16 milligrams per kilogram. 16. That's the emergency dose.
That's the undo button. Second, deep block. Your monitor shows a post-tetanic count of 1 or more, but no train of 4 twitches. The dose is 4 milligrams per kilogram.
4 for a deep block.
Right. And third, routine reversal at the end of a case. You've got 2 or 3 twitches back. This is a moderate or shallow block. The dose is 2 milligrams per kilogram.
So the takeaway is that you can reverse at any level of block just by adjusting the dose.
That is the essential clinical advantage over Neostigmine.
So let's summarize the advantages that justify its higher cost.
1, speed and predictability. 2 to 3 minutes every time with no ceiling effect.
2.
2, safety. You don't need an anti-muscarinic, so you avoid all those cholinergic side effects, the bradycardia, the bronchospasm.
And 3.
3, clinical flexibility. It makes Rocuronium a viable and often superior alternative to succinylcholine for RSI because you have that 16 millikilogram escape hatch.
Okay, what about the risks? What do we need to tell the examiner? It's generally very safe, but there are 3 things to mention. First, hypersensitivity. There's a small but real risk of allergic reactions, including anaphylaxis. Second, bradycardia. It has been reported, though it's much less common and usually milder than with Neostigmine.
And third, recurization.
This is a key conceptual point, even though it's rare. It happens if you give a suboptimal dose, like 0.5 milligen kilograms, for a really deep block.
And the mechanism is what?
It's thought to be redistribution. The small dose clears the drug from the plasma, but then more Rocuronium slowly leaches out from the peripheral tissues, overwhelming the small amount of Sugammadex you've eaten. It proves why correct dosing is non-negotiable.
Okay, this whole discussion builds to this point. The direct comparison, the perfect 20-mark question. Let's do a rapid-fire breakdown.
Let's do it, a head-to-head.
Mechanism of action.
Neostigmine. Indirect. A key E inhibitor. Sugammadex. Direct.
No.
Encapsulation.
Speed of reversal.
Neostigmine. Slow and variable, 15 to 20 minutes. Sugammadex. Rapid and predictable, 2 to 3 minutes.
Depth of block reversed.
Neostigmine. Shallow block only. You need 4 twitches. Sugammadex. Any depth. Deep, profound, doesn't matter.
Anticholinergic requirement.
Neostigmine. Mandatory. Requires Glycopyrrolate. Sugammadex. None required.
Sector of action.
Neostigmine. Broad. Works for all endemars. Sugammadex. Narrow. Steroidal agents only.
Okay, patient-specific impacts.
Neostigmine's effect is impaired by acidosis. Sugammadex complex can accumulate in severe renal failure.
And the elephant in the room. Cost.
Neostigmine is cheap. Sugammadex is expensive. You have to mention that this cost difference is the biggest barrier to its universal use.
Which leads to clinical indications.
Neostigmine is for routine reversal of shallow block, or if you've used Acetylcholinesterase. Sugammadex is for any time you've used Rocuronium or Vecuronium and you need speed, predictability, or reversal from a deep block, or if the patient has cardiac or pulmonary issues.
Okay, let's put this into practice. Clinical scenarios. This is where you show you can think, not just memorize.
Let's do it.
Scenario 1. Routine 90-minute surgery. You've used Rocuronium. You see 3 twitches back. What's the choice?
Sugammadex 2 milligrams per kilogram is the strongly preferred choice.
Even with the cost?
Yes, because while Neostigmine could work, you're buying yourself a 15 to 20-minute wait in the OR. That has its own costs in terms of turnover and PCU time. Sugammadex gives you a guaranteed recovery in 3 minutes. It virtually eliminates the risk of RNMB. It's safer and more efficient.
What if you use Acetylcholinesterase in that same scenario?
Then Neostigmine is your only option. But you have to stress the process, wait for 4 twitches, give a conservative dose, and then you must use your quantitative monitor to confirm a TOFR of 0.9 before you extubate.
Scenario 2. RSI with Rocuronium. This one is non-negotiable, right?
Absolutely. You've given a huge dose, 1.2 milligrams per picogram. Intubation fails. The block is profound. PTC is 0. Neostigmine is completely useless here.
So it has to be.
16 milligrams per kilogram of Sugammadex. It's the immediate undo button. It changed the entire risk calculus of RSI.
Okay, special populations. A patient with significant cardiac disease. What's the risk with Neostigmine?
The big risk is that M2 receptor stimulation, causing severe bradycardia. Even with glycopyrrolate, you can get heart rate instability, which is something you desperately want to avoid in a patient with poor cardiac reserve.
And Sugammadex.
Decidedly safer. It completely avoids that cholinergic stimulation. It offers a much more stable hemodynamic profile.
What about a patient with bad asthma or COPD?
This is a textbook comparison. Neostigmine is uniquely dangerous here. The M3 receptor stimulation causes bronchoconstriction and increases secretions. It's the last thing you want during emergence.
And Sugammadex is the clear winner.
It's the strongly preferred agent. By avoiding those muscarinic effects, you minimize airway reactivity and ensure a much smoother, safer wake-up.
Last one. Renal failure. They both have clearance issues, but they're different.
With neostigmine, about half of it is cleared by the kidneys, so its effect can be prolonged. But honestly, you're often more worried about the prolonged effect of the relaxant itself in these patients.
And for Sugammadex, where the whole complex is renally cleared.
In severe renal failure, GFR less than 15, the complex will accumulate. And while reversal is still effective, we don't have a lot of long-term data on the safety of that accumulation.
So it's used with caution.
It is. But it's important to know, for an exam, that the complex can be effectively removed by high-flux hemodialysis.
Okay, let's nail down some Viva points. Short, sharp questions to test critical thinking.
Let's do it.
Examiner says, the patient lifted their head for 10 seconds. Their tidal volume is great. Can I extubate?
The answer is an immediate and firm no. You have to say clinical signs are unreliable. You quote the stats. Head lift can be present with 33% block, tidal volume with 70–80% block. Then you pivot to the safe standard. Safe extubation requires objective confirmation of a TOFR of 0.9 or greater.
Why does AMG need a target of 1.0?
Because AMG, the technology, tends to overestimate the degree of recovery as you get close to 0.9. So to be sure you're truly at 0.9, you need the monitor to read 1.0. That's a detail that shows real mastery.
Define the ceiling effect of neostigmine.
The ceiling effect is the point where the acetylcholinesterase enzyme is maximally inhibited. Giving more drug is futile because you can't raise the ACE2 concentration any higher. This is why it only works for shallow block.
Explain the mechanism of paradoxical weakness with neostigmine.
It occurs when you give a high dose to a fully recovered patient. The massive excess of acetylcholine causes prolonged depolarization of the motor end plate, inducing a depolarizing phase I-like block.
Okay. Viva points on Sugammadex, the one non-negotiable term for its action.
Cyclodextrin encapsulation. You have to use that term.
Proposed mechanism of recurization.
Redistribution kinetics. An inadequate dose clears the central plasma pool, but then relaxant slowly redistributes from the peripheral tissues, overwhelming the limited Sugammadex and causing the block to return. It's all about correct dosing.
How does Sugammadex change Rocuronium's elimination?
It shifts it completely from a primarily biliary route to a 100% renal excretion of the complex.
Let's talk exam traps. Reversing a phase 2 succinylcholine block with neostigmine. Why is this a bad idea?
This is a classic trap because neostigmine inhibits not only acetylcholinesterase but also plasmacholinesterase, the enzyme that breaks down succinylcholine.
So you could actually make the block much, much worse.
Catastrophically worse, especially if the patient has an atypical enzyme. The safe answer is do not do this unless you are absolutely certain all circulating succinylcholine is gone, which is almost impossible to know.
In a long answer question, diagrams are huge. What are the two mandatory diagrams here?
Absolutely non-negotiable. First, the neuromuscular junction. You draw the pre- and post-synaptic structures.
What are the key labels?
You have to label the nicotinic ASHA receptors, show the two alpha subunits as the binding site for the NDMR, and you must draw and label the acetylcholinesterase enzyme in the cleft, showing neostigmine inhibiting it.
And the second diagram?
The encapsulation mechanism. You draw Sugammadex as a hollow cone or donut. Label the hydrophobic core and the hydrophilic exterior. Then show the Rocuronium molecule being trapped inside in a 1-to-1 ratio.
And you have to show the concentration gradient.
Yes. Use arrows to show the Rocuronium leaving the receptor and being pulled into the plasma to be captured. That visually explains the mechanism.
Last piece of strategy. How do you structure a 20-mark answer on this?
Structure is everything. Start with an introduction defining RNMB and why it's a problem. Then a section on the physiological basis, then a detailed section on neostigmine, then a detailed section on Sugammadex.
Including doses and limitations.
Of course. Then a comparative analysis, preferably in a table. Then clinical applications in different scenarios. And finally, a strong conclusion summarizing the modern paradigm.
That's the blueprint. Okay, let's wrap this up with a final summary. The absolute must-know points.
Here are the 12 critical facts to take into the exam. 1. RNMB incidence is 30 to 50% without monitoring. 2. Failure to reverse increases pneumonia risk 2.26 times. 3. Safe extubation requires a TOFR of 0.9 or greater. 4. Neostigmine is an indirect ACE inhibitor and needs glycopyrrolate. 5. Neostigmine can only be used when you have 4 twitches back. 6. Neostigmine has a ceiling effect. 7. Neostigmine can cause paradoxical weakness.
Halfway there.
8. Acidosis impairs neostigmine. 9. Sugammadex is a direct encapsulating agent. 10. Sugammadex only works for Rocuronium and Vecuronium. 11. The Sugammadex doses are 16, 4, and 2 milligrams per kilogram, depending on block depth. And 12. Sugammadex is rapid, predictable, and avoids muscarinic side effects.
Perfect. Now give us that model conclusion paragraph to end a top-scoring essay.
Okay. The modern reversal paradigm is defined by the absolute mandate for objective, quantitative neuromuscular monitoring to eliminate the significant risk of residual block. Agent selection is stratified by pharmacology and block depth. Neostigmine remains essential for a minimal block of non-steroidal agents, but its use must be carefully timed and dose-limited. Conversely, Sugammadex has revolutionized the management of aminosteroidal blocks by providing rapid, reliable reversal from any depth, offering superior safety in high-risk scenarios and establishing itself as the gold standard for aminosteroid reversal.
You have just given our listeners the complete blueprint. That was a truly comprehensive deep dive.
It's a great topic because you can see how molecular science directly improves patient safety.
To our listener, as you study this, try looking up the actual structural differences between the cyclodextrins. See why the gamma variant was the one they chose to modify for Rocuronium. It's fascinating.
And I'll leave you with a final thought, a real-world dilemma. We know Sugammadex is safer and more convenient, but it's expensive. So how do we, as a healthcare system, ethically decide when its superior safety is mandatory versus when meticulous monitoring and cheap neostigmine is an acceptable, cost-effective standard?
That tension between what we can do and what we should do is what will define your practice. Thank you for joining us for the deep dive.
Keep thinking critically.
Study hard, and we'll catch you next time.